PUO or FUO, Biorexia of unknown origin, or fever of unknown origin. Definition: fever of unknown origin, FUO, or Biorexia of unknown origin, BO, was defined in 1961 by Petersdorf and Beeson as the following. Number 1, temperature greater than 38.3 degrees centigrade, means 101 degree Fahrenheit on several occasions. Number 2, more than 3 weeks duration of illness. Number 3, failure to reach diagnosis despite 1 week of inpatient investigation. This means that the definition requires in-hospital stay for at least 1 week duration and duration of fever more than 3 weeks. The newer definition will eliminate the need for in-hospital stay, so it requires only 3 days in hospital or 3 outpatient visits to specialist doctor. So ambulatory as well as in hospital stay, it doesn't make difference is this in this newer definition. Epidemiology and etiology of PUO. Number 1, infections. 30 to 40% of cases. Neoplasm, 20 to 30% of cases. And there is interaction between these two major causes of PUO. Infections seems to be more prevalent in developing countries. However, neoplasm is more prevalent in developed countries. It means that tumor and malignancy is more prevalent in developed countries and infection more prevalent in developing countries. The third main cause is collagen vascular disease, 10 to 20% of cases, miscellaneous diseases, 15 to 20%, and finally undiagnosed cases, from 5 to 15% despite exhaustive studies. Means that there is a good percent of patients who do not reach any diagnosis for the cause of PO despite a long list of exhaustive investigation, and the cause of PO remain unknown. Finally, POs that persist more than 1 year do not seem likely to be due to infection or neoplasia. It may result from collagen vascular disease or granulomatous disease. There is a special situation or special patient with PO. The first one is nosocomial PO. Nosocomial PO means hospital-associated or hospital-acquired PO. It means that the patient acquired PO due to his hospital inpatient hospital stay or hospital visit. The first is surgery. Second, urinary catheterization. The third, intravascular device due to cannula, CVB, and whatever. The third is the use of certain drug. Either the drug itself is the cause of fever, as in drug fever, or the use of this drug lead to situation which lead to PO, as antibiotic-induced Clostridium difficile colitis. Some patient with prolonged immobilization may have PO due to immobilization, as in decubitus ulcer, deep venous thrombophlebitis, and pulmonary embolism. Transfusion reaction due to fluid transfusion or blood transfusion or blood product, acalculous cholecystitis, thyroiditis, alcohol and drug withdrawal, which is very important, alcoholic patient or drug addict due to his hospital stay may be away from alcohol or from his drug dealer, so the withdrawal manifestation of this drug may prevail, and one of these manifestation is fever, adrenal insufficiency, pancreatitis, sinusitis, and another long list of cases. The second special situation is Biorexia of unknown origin. It is not of unknown origin in HIV patient. HIV itself may be a cause of PUO, and the patient may be not aware of his disease. Secondary causes: HIV patient may be prone to tuberculosis, toxoplasmosis, pneumocystis carinii infection, which cause some sort of pneumonia. It is called pneumocystis carinii or pneumocystis jirovecii. Cryptococcosis, a type of fungal infection, salmonellosis, histoplasmosis, cytomegalovirus infection, and in some patients, non-Hodgkin lymphoma or Kaposi sarcoma, and drug-induced. The third special situation is PO in transplant patient. This is special category. It may be due to infection, episodes of graft rejection in solid organ transplanted recipient, or the second is graft versus host disease in hematopoietic stem cell transplantation. And the difference between these two types of rejection, solid organ rejection in transplanted patient, means that this strange organ, which may be liver, kidney, or whatever, is attacked by the immune system of the body. So we give the patient some sort of immunomodulator and immunosuppressant drug to stabilize this organ, this strange organ which transplanted in the host. The reverse occur in hematopoietic, the patient with stem cell transplantation or bone marrow transplantation. We put abnormal bone marrow or new bone marrow inside the host. So the immune system, the strange immune system, which is put in the bone marrow of the patient, attacks the whole body. So it's called graft versus host disease. That the grafted organ, which is not organ, which is the stem cell in the bone marrow, attacks the whole body of the transplanted patient. These two causes may lead to PO. According to time following transplantation in solid organ transplantation, we can categorize from 0 to 1 month. Bacterial or fungal infection may be prevalent in this period and considered as a cause of PO, or surgical complication may be considered here to be the main cause of PO. From 1 to 6 months, cytomegalovirus or eventualistic infection as pneumocystis carinii or pneumocystis jirovecii pneumonia. More than 3 months duration means that bacterial pneumonia, community-acquired infection, post-transplant lymphoproliferative disorder may be the main cause in this special category. This is the classification of PO. So it's 4 major types. The classic one, nosocomial one, PO in immune deficient neutropenic patient, and PO in HIV associated patient. Etiologies of PO, returning to the etiologies one by one. The first one is infections, which is the main cause of PO in developing countries. Infection is a large group of organisms that cause PO, but to specify this, we put special categories: specific location, specific organism, and specific patient groups. Specific locations. There is specific location in which infection may be hidden and may be a cause of PO. The first is abscesses, mainly deep-seated abscesses, may be cause of PO, and the patient is not aware that he had abscess and the only complaint is fever. The second is hepatobiliary infection. Ascending cholangitis, calcular cholecystitis, or whatever may be a cause of PO, and the patient is not aware that he had infection in this site. diverticular disease. Colonic diverticulosis, it means that there is outpouching from the outer wall of the colon. It may act as simulating the appendix and may have inflammation, so the patient has diverticulitis, which is similar to appendicitis and may be chronic and may be multiple, and the patient is not aware that he had infection in his colon and it is maybe the cause of fever. UTI, urinary tract infection, including prostate infection, may be a cause of PUO. Pulmonary infection, starting from atypical pneumonias to TB, may be a cause of PUO. CNS infection, oral cavity infection, including dental abscesses, may be cause of PUO. Head and neck, including nasal sinuses, chronic sinusitis, may be cause of PUO. Bone and joint infection, especially in special patients like diabetic patient, chronic bone infection or joint infection may be present and may be cause of PUO. Infective endocarditis. Infective endocarditis may cause fever, prolonged fever, and if not treated, it may be a life-threatening condition. So there is specific location in infectious patient may be a special cause or of high risk for PUO. Specific organisms. Some organisms may cause PUO due to its chronicity and its ability to induce fever. The first one is TB, tuberculosis, especially extrapulmonary type, may cause PUO. Tabes mesenterica or abdominal TB, urinary tract tuberculosis, may be a particularly cause of PUO. Brucellosis, brucella may cause PUO. Some chronic viral infection like cytomegalovirus infection or Epstein-Barr virus infection, HIV infection, AIDS patient may have presented by PUO for a long time before the appearance of manifestation or other manifestation of HIV infection. Some fungal infection like Candida aspergillus group may cause PUO. So there is a specific organism which has the ability to cause PUO. And this is a list of the most common bacterial, viral, parasitic, and fungal diseases which may cause Biorexia of unknown origin. Lastly, specific patient group. Some patient have specific criteria which prone them to specific infection. The first one is imported infection. We have malaria, dengue fever, rickettsia, brucella, babic liver abscess, enteric fever, and leishmaniasis. These all diseases are more prevalent in some countries. Malaria, for example, is more prevalent in some areas in Africa, Middle East, and Southeast Asia. So any patient there, the doctors there will think about malaria. But if any patient from there came to Egypt and is presented with fever, we will not think about malaria as the first cause of fever. So we must know the traveling history of the patient, because some diseases are specific in some countries and a lot of them is a cause of PUO. You must think if this patient abroad for a long or short time and for how long and where and when he came to us. The second is nosocomial infection. For example, fever related to prosthetic material and surgical procedures. Plate and screw, prosthetic valve, in some patient with heart diseases may be the main cause of PUO. And also HIV positive individuals. Acute retroviral syndrome, defining infection, disseminated myocardium avium complex, pneumocystis jirovecii, pneumonia, cytomegalovirus, and others. So there is specific patient with a specific category and stigmata which make him more prone to some infections. And this is the third one. So in infection, we must know what is the specific site, what is the specific organism, and what is the specific patient group to categorize the cause of infection exactly in this patient. The second cause of PO, which is more prevalent in developed countries, is tumor or malignancies. What is the most common cause of tumors which lead to fever and prolonged fever, which can be defined as PO? The first is hematological malignancy, lymphoma, leukemias, and myeloma. Multiple myeloma is the main cause of hematological malignancy which lead to PO. The second group is the solid tumors, mainly kidney and liver. Renal and hepatocellular carcinoma as the main cause of HCC in solid organ tumors. Also, chronic gastric and pancreatic carcinoma can be a cause of PO. The third large group is connective tissue disorder. In older adults, giant cell arthritis, polymyalgia rheumatica may be a cause of fever. In younger adult, the famous rheumatic fever, it is called rheumatic fever, one of the main cause of PO. Still's disease, which is juvenile rheumatoid arthritis with vasculitis, is a special type of rheumatoid because rheumatoid disease itself, the classic rheumatoid, is not presented with fever, but Still's disease, special type of juvenile rheumatoid arthritis, can be presented with fever. Systemic lupus erythematosus may be presented with fever due to its vasculitis. Vasculitis disorder like polyarthritis nodosa and Wegener granulomatosis, polymyositis, and the famous Behçet disease, which is present in some localities, including Egypt. The fourth main group of PO is miscellaneous, which can be categorized in the following disease. Cardiovascular disease like the atrial myxoma, aortitis, aortic dissection may be a cause of PO. Respiratory disease like pulmonary embolism, sarcoidosis, extrinsic allergic alveolitis may be cause of PO. Gastrointestinal disease like inflammatory bowel disease, mainly Crohn's disease, granulomatous hepatitis, alcoholic liver disease, and pancreatitis. Endocrine disorder, the famous thyrotoxicosis with its thyrotoxic crisis and fever and hyperpyrexia, thyroiditis, pheochromocytoma, which is famous due to high adrenaline dose, which can cause fever, and exceptionally adrenal insufficiency. In some cases with adrenal insufficiency may be presented with fever, but the most common is the multiple hypotension and hypothermia and the famous multiple hypos which occur with adrenal insufficiency, but in some cases adrenal insufficiency is presented with PO. Hematological malignancy, all hemolytic anemia can be presented with PO. Paroxysmal nocturnal hemoglobinuria, which is one of the hemolytic anemias, thrombocytopenic purpura, and myeloproliferative disorders. Some inherited disease like the famous familial Mediterranean fever and periodic fever syndromes. Drug reaction like antibiotic fever, drug hypersensitivity reaction, factitious fever, and idiopathic cause, which we will not reach any diagnosis despite of exhaustive investigations. All are known except this factitious fever. What is the meaning of factitious fever? Factitious fever means that malingering patient pretend to have fever for benefit. He needs sick leave, he needs vacations, he needs insurance, he needs a benefit, so he is pretending to has a fever. What's criteria for this patient? The patient looks well. He is not toxic, he is not sweaty. Bizarre temperature chart with absence of diurnal variation and or temperature related change in pulse rate. Any patient with fever must has a high pulse rate. 1 degree centigrade elevation means at 10 beats more per minute. Temperature is more than 41 degree centigrade. Absence of sweating during defervescence. The patient with fever, during withdrawal of this fever, the patient got sweaty. And this sweating occur with drop of body temperature. So absence of this sweating during drop of this temperature is with factitious fever. Normal ESR, erythrocytic segmentation rate, and C-reactive protein despite high fever. Evidence of self-injection or self-harm. He is not psychologically stable patient. Normal temperature if we catch this patient and put him in hospital for supervision, so the temperature become normal. Malingering patient induced fever by eating some noxious material. بيعملوها أكتر مع الحلاوة الطحينية مع الشطة. So it will lead to high vascularity in the oral cavity. So during measurement of blood of body temperature, the body temperature will be elevated. And this is eliminated by the newer infrared devices. Also, he can inject himself with some irritant material like subcutaneous alcohol, which induce chemical reaction leading to fever. So the patient will came to you with high fever, but with this criteria. He do this for insurance. عايز ياخد فايدة من التأمين الصحي, or for vacation, or for sick leave. عايز ياخد أجازة. So he's induced this fever and he assume or pretend that this fever is prolonged, so he had something wrong, malignancy, chronic infection, so he can get benefit. And this is called factitious fever. اوعوا يا دكاترة عيان يضحك عليكم ويستعبطكم وياخد فايدة وانتم مش واخدين بالكم. What about drug-induced fever? There is a long list of drugs that can cause fever. The most important is antibiotic. The antibiotic culprit for fever is erythromycin, isoniazid, penicillin, nitrofurantoin, and quinidine. What is the most common presentation of these antibiotics? These antibiotics can be used for a long period. Erythromycin and penicillin can be used as a prophylaxis in patients with rheumatic fever. Isoniazid can be used in patients with TB. It is for long period, 6 months or even 1 year duration. Nitrofurantoin, intestinal antiseptic, and can be used for a long period. Quinidine is one of the treatment of malaria and can be used for a long period. So antibiotic for long period, especially these group, can cause fever. Because the short course of antibiotic, which will take 5 or 10 days or even 14 days, 2 weeks, will not fulfill the criteria of fever, which lasts for 3 weeks, which is the original definition of PUO. So antibiotic which can be used for a long period can be cause of PUO. The second is the cardiovascular system related drug, captopril, nifedipine, alpha methyl dopa. These are antihypertensive. Clofebrate, antihyperlipidemic. Hydralazine, atropine, hydrochlorothiazide. This is diuretic. These can cause fever, and also cardiovascular system drug can be used for a long period, so the patient can be presented with PUO. Approach to patient with PUO. how we could manage patient presented with PUO. It can be divided into 4 stages. The first one, stage 1, careful history taking, physical examination, and routine screening tests. The second stage, review for the history and repetition of the physical examination. Stage 3, specific diagnostic test and non-invasive investigation. Lastly, stage 4, invasive test. So, to approach patient with PUO, we'll approach him in different stages according to the difficulty for the diagnosis of this patient. The first is the history. Specific history is very important in patient presented with PUO and must include the following. The first, duration and the characteristic of fever, number of peaks or spikes of fever per day, timing of temperature elevation, is it diurnal or nocturnal, whether temperature return to normal or below normal. The second is traveling history. Travel history or exposure to people who have traveled to region endemic for particular disease like malaria, tuberculosis, typhoid fever, toxoplasmosis, visceral leishmaniasis, and whatever. Exposure to any animal. Some diseases can be transmitted from animals and some of them can be presented with PUO, like cat scratch disease, rat bite fever, leptospirosis. Exposure to unpasteurized dairy product, which may lead to infection with brucella. Presence of rash, conjunctivitis, mucous membrane changes, and arthritis. It mainly occur with collagen vascular disorder, like in case of juvenile rheumatoid arthritis, systemic lupus erythematosus, Kawasaki syndrome. Presence of associated cough, weight loss, or lymphadenopathy, which may occur in lymphoma, leukemia, neuroblastoma, tuberculosis, and HIV infection. Pattern of fever, characteristic. There is many types of fever. Continuous fever, does not remit, always elevated, occur in typhoid fever, drug fever, malignant hyperthermia. Intermittent fever means that temperature fails to normal every day, occur with biogenic infection, lymphoma, miliary TB. Remittent means that there is fluctuation, but the fever do not return to normal, always elevated, but with fluctuation, occur with biogenic abscess. Relapsing fever means that days with temperature elevated and days with normal temperature before rising again, occur in malaria, occur in brucella, some types of lymphoma like Hodgkin lymphoma, and some types of biogenic infection. This is a pattern of fever. We have a step ladder type, which is specific to typhoid, intermittent, which turn to normal, Bell-Epstein fever, occur in Hodgkin lymphoma, intermittent fever, and whatever. And this is a picture of fever chart. This is a graph for fever which can be drawn to every patient presented with PUO. Physical examination in patient with PUO. Physical examination must be meticulous, repeated, and on regular basis. We must see and examine the patient repeatedly. We must do temperature chart. We must examine skin, lymph nodes, eye, nail beds, cardiovascular system, chest, abdomen, musculoskeletal system, CNS, and we must examine the genital area in both male and female, because some and a lot of diseases sexually transmitted may be presented with PUO. So physical examination here to localize, to see any localizing manifestation which may cause PUO. Abdominal tenderness, presence of deep-seated abscess, presence of tender joint, presence of skin manifestation and nail bed manifestation, which may, like splinter hemorrhage, which may denote that patient may have some sort of toxemia or some sort of infective endocarditis, conjunctivitis, manifestation of drug, multiple drug injection in drug user. So this examination must be meticulous and must be repeated, and you must search for any localizing manifestation which may be the cause or the clue of presence of PUO in such patients. Minimal diagnostic workup to qualify a case with PUO, comprehensive history and physical examination, CBC with differential count, blood film in some cases like thick blood film or thin blood film in patients with hemoparasites, routine blood chemistry, urine analysis, blood or urine culture 3 times, antinuclear and rheumatoid factor, human immune deficiency virus in some situation, cytomegalovirus serology, Q fever serology, chest radiography, hepatitis serology, and etc. What about patient presented with PUO and you are searching for infectious causes, which is the main cause in developing countries? Microbiological investigation in case of PUO, it includes direct microscopical examination of the offending cause, culture and sensitivity in some situation, antigen detection, nucleic acid detection, and immunological test. Direct identification of the organism by microscopy can be confirmed in case of blood examination, blood film for direct identification of organisms like malaria and trypanosomiasis, atypical lymphocytes in case of Epstein-Barr virus, cytomegalovirus, and HIV infection. In some patients with toxoplasma, there is atypical large lymphocytes which can be misleading as a case of hematological malignancy. Sputum examination for direct identification of mycobacterium and fungi. TB can be diagnosed by 3 successive sputum examination by Ziehl-Neelsen. Stool examination for presence of ova and cysts of some parasites. Urine examination for pus cells, presence of RBCs, schistosoma ova, mycobacterium in case of urinary TB. Early morning urine is important. 3 days examination or 3 times is very important. Light microscopic examination and biopsy for bacteria, mycobacteria, fungi, leishmania, and other parasites. And in some situation, electron microscopy for examination of some types of viruses and some types of protozoa. This is direct identification of the offending cause by microscopy. Culture sensitivity can be done in patient presented by PUO. We can culture blood and must be 3 times cerebrospinal fluid culture, gastric aspirate for some case of mycobacterial infection, stool culture in some patient, swab, either throat swab or swab from any virulent discharge from abscesses, urine and prostatic massage in some patient, aspirate and biopsy, patient presented with pus in the joint, deep-seated abscess, debrided tissue due to post-operative infection or whatever. We can aspirate and swab this area, and we can do culture and sensitivity to determine the offending organism and the best antibiotic after culture sensitivity. Antigen detection. In some patient and some infection, we can detect specific antigen present in the surface or inside the offending cause, so we can identify the offending organism. We can detect antigen of HIV, which is called the B24 antigen, cryptococcal antigen. Cryptococcus is one of the famous fungal infections. Histoplasma antigen is also one of the famous fungal infection. Aspergillus is the same group, using ELISA technique. We can use CSF for cryptococcal infection in some patients with cryptococcal infection of the CNS. BAL, which is bronchoalveolar lavage, for Aspergillus infection, also for TB. We can detect some sort of presence of aspergillosis or pulmonary TB. Nasopharyngeal aspirate, throat swab for respiratory virus. We use this nasopharyngeal aspirate and throat swab for diagnosis of the famous COVID-19, which is acute, not chronic. Urine for Legionella infection. Legionella, it causes atypical pneumonia, and some of the antigen of this organism is secreted in urine. So we can diagnose one of the atypical pneumonia by using antigen detection in urine. Nucleic acid detection, it means that I can detect a specific sequence of DNA or RNA of the organism inside the specimen. The famous nucleic acid detection is the PCR, polymerase chain reaction, which is used for detection of hepatitis C and whatever, a lot of organisms. We can use this technique for detection of presence of specific chronic infection, which can cause PUO. Blood for Salmonella, Brucella, and some viruses. CSF for some viruses and bacteria, as meningococcus or pneumococcus infection. Nasopharyngeal aspirate or throat swab for respiratory viruses. Bronchoalveolar lavage for respiratory viruses. Tissue specimen for TB and other infection. Urine for chlamydia and Neisseria gonorrhea. Stool for norovirus and rotavirus. So nucleic acid detection is a powerful tool which can be used for detection of chronic and scanty infection. We can amplify the small amount of DNA specific or RNA specific for this organism, so we can detect it easily. This process is called nucleic acid detection, and the most famous one is the PCR technique, which is the polymerase chain reaction. Lastly is immunological test. Immunological test means that I detect antibody or a specific material present in the serum or in the sample which react with this specific organism or this specific infectious agent. This is the cheapest mode to detect infection, but a lot of question mark applied here in patient with PUO. PUO is patient presented with fever, and the fever puts patient in a special situation. He has a high ESR, high C-reactive protein, high antibody level presence in the blood, presence of high level of immune reactant and cytokines, which means that specific antigen antibody reaction may be not present in this situation. So tests depending on presence of specific antibody to specific antigen to organism may be misleading in this situation. We can apply this for typhoid fever. Patient with typhoid fever, when we do some serological test, which is called the Vidal test, which depend on O antigen and H antigen. O is a somatic antigen and H is flagellar antigen, which can differentiate between recent and old and can differentiate between typhoid and paratyphoid fever. When we apply this test in patient with PUO, we have a lot of false positive result. Patient presented with lymphoma or leukemia or hepatocellular carcinoma presented with PUO for a long period. When you do this Vidal test, you will notice that all the test is positive. O positive, H, all type of H are positive in a high titer, due to something called amnestic reaction or false positive reaction due to presence of high antibody level, non-specific, which can react with the specific antigen for typhoid fever. So serology must be guarded in patient presented with PUO. It is the cheapest mode, the cheapest test, and the most widely prevalent test. We can't, in a situation, detect specific organism under microscope, or we can't use PCR because it's very expensive in some patient. So serology is widespread and cheap. Serology is applied for viruses, dimorphic fungi, and some bacteria and protozoa. Serology for cytomegalovirus infection, Epstein-Barr infection, infectious mononucleosis, HIV infection, typhoid fever, brucellosis, amoebiasis, toxoplasma, chlamydial disease. And as I said before, it is guarded because in a lot of situations, false positive result occur and it may be misleading. Serology for connective tissue disorder, antibody screening, complement level, immunoglobulins, cryoglobulins, and something called the gamma or interferon gamma release assay for diagnosis of TB. It's called the quantiferon test. It's one of the very powerful tools to identify TB, especially extrapulmonary type. Serum protein electrophoresis, it's useful in diagnosis of atrial myxoma, systemic lupus erythematosus flare, and some types of lymphoma. Serum ferritin level, useful in case of PO due to malignancies, systemic lupus erythematosus, and juvenile rheumatoid arthritis stem disease. Other tests, plain X-ray, like plain chest X-ray, which can detect the cavitary lesion for TB or atypical pneumonia. Also plain X-ray for bone and joint, which can detect the presence of osteomyelitis or arthritis. Abdominal ultrasound is very important for detection of deep-seated intra-abdominal abscesses or presence of Hebetobiliary infection. Echocardiography, which can detect the presence of infective endocarditis, atrial myxoma, and whatever. CT and MRI, whether for abdominal or musculoskeletal system. Isotope bone scanning, it's the famous technetium 99, radioactive material labeled on RBCs, which can be present in metastatic lesion, polymetastatic lesion, or in case of osteomyelitis. Labeled white cell scan, Positron emission tomography, it is a famous PET scan, and biopsy. Positron emission tomography depend on combination between CT with dye and presence of radioactive glucose. It depends on the idea that malignant tissue has a high metabolic rate, so it consumes glucose very rapidly. With infusion of radioactive glucose, the malignant tissue appear as hot dots, so it can detect the presence of primary lesion and secondaries and follow up of tumor after chemotherapy or after surgery. Here, special conditions with PO. The first is endocarditis. Endocarditis has specific points. First is culture negative endocarditis occur in high proportion of patients due to prior antibiotic therapy. In a patient presented with PO, he may use antibiotic or for long or short period, and when echocardiography was done and the patient has a vegetation in his heart or presence of any manifestation of endocarditis, so he had previous antibiotic therapy, so culture will be negative. In hepatobiliary infection, cholangitis can occur without local signs and with only mild elevation of normal finding of liver function test. So it may be a hidden cause of infection and may be not diagnosed. Osteomyelitis also. In osteomyelitis, plain radiography may not show changes for weeks after development of symptoms. And here, MRI and technetium labeled RBCs is the most sensitive diagnostic tool. In some rickettsial and chlamydial infection, Coxiella burnetii, which is famous Q fever, can be identified in patients with PUO with signs of hepatic involvement and can be transmitted from cows and sheep. Chlamydia stacey infection, which causes atypical pneumonia, transmitted from birth. Lymphogranuloma venereum, which is sexually transmitted disease. Serology is one of the most diagnostic useful tool in this rickettsial infection. Systemic bacterial illness. Some systemic bacterial illness can be manifested as PUO. The most famous one is TB, especially the extrapulmonary type. Brucellosis is one of the famous causes of PUO in Mediterranean area, also including Egypt. Also systemic infection with Salmonella, Neisseria meningitis, Neisseria gonorrhea as a cause of PUO. Culture and serologic tests established to diagnose this infection with a lot of question mark about serology in such situations. Viruses. In case of cytomegalovirus and Epstein-Barr virus, presence of atypical lymphocytes is very important in blood film. Serological test is very important, and be notes that the result of these serological tests may be initially negative, therefore must be repeated in suspected cases 2 or 3 weeks after the onset of illness. Fungal infection. Candida albicans the main cause of disseminated fungal infection. Systemic infection may remain undiscovered because blood culture are negative in approximately half of these cases, and also blood culture for fungal infection has a special precaution and must be done in a special situation. Parasitic infection. Toxoplasmosis is the main cause of PUO. Presented with lymph node enlargement, diagnosis can be difficult to establish because lymph node may be small. Rising antibody titer and immunoglobulin M antibody confirms diagnosis. In some cases, retinal examination leads to presence of special lesions, which is specific for toxoplasma. Lymphoma. The correct diagnosis of Hodgkin or non-Hodgkin lymphoma can be delayed if the tumor is difficult to detect when the disease is confined to the erythroperitoneal deep-seated lymph nodes. Anemia may be the most prominent laboratory abnormality in such patients. Leukemias. Acute leukemia are another important neoplastic group that cause PUO. In pre-leukemic state, the peripheral blood smear and bone marrow aspirate may not reveal the correct diagnosis and therefore perform bone marrow biopsy. Solid tumors. Renal cell carcinoma is the most common associated with PUO, with fever up to 10% of cases, hematuria up to 40% of cases. Anemia and high elevated sedimentation rate are very common. Also, hepatocellular carcinoma may be presented with PUO, and the combination of PUO, elevated liver enzymes, elevated alkaline phosphatase, Biorexia, anemia can reach the diagnosis, and the final diagnosis is reached by radiology. Renal arthritis or Crohn's disease is the most common cause of gastrointestinal causes of PUO. Diarrhea, abdominal pain, bleeding per rectum is occasionally present, and diagnosis is established by doing endoscopy. Granulomatous hepatitis. In some patients with hepatic granuloma, none of the disease usually associated with PUO. TB, syphilis, brucella, sarcoidosis, Crohn's disease, Hodgkin disease may be a cause of hepatic granuloma, and all are presented with fever and PUO. Any elevation in the alkaline phosphatase level is the most consistent laboratory abnormality. Alkaline phosphatase, especially the hepatic alkaline phosphatase, is a marker of cholestasis and a marker of hepatic infiltration. So any mass occupying lesion inside the liver, it leads to elevation of hepatic alkaline phosphatase. Collagen vascular and autoimmune disease. Systemic lupus erythematosus can be diagnosed easily by demonstrating anti-nuclear antibody positive titer in the serum of the patient. Systemic onset juvenile rheumatoid arthritis is often difficult to diagnose. Laboratory abnormality include pronounced leukocytosis, elevated erythrocytic sedimentation rate, anemia, abnormal liver function test, and these findings usually trigger to search for infectious cause rather than collagen disease, which can delay the correct diagnosis. Giant cell arthritis. Laboratory findings in giant cell arthritis include elevated ESR, mild to moderate normocytic normochromic anemia, elevated platelet count, and abnormal liver function test. And the final diagnosis is reached by biopsy from the temporal artery. PUO and rash. The most common causes of PUO presented by rash is rheumatic fever, vasculitis, inflammatory bowel syndrome, and systemic lupus erythematosus. What about familial Mediterranean fever? Familial Mediterranean fever is one of the causes of PUO. Familial Mediterranean fever is also called recurrent polyserositis. It causes recurrent inflammation of the serosal membrane. The main feature of familial Mediterranean fever include brief recurrent episode of peritonitis, Biorexia, arthritis, usually accompanying fever. Brief, it is not so brief. Patients presented with severe abdominal pain resembling acute appendicitis, and this is the main cause of hospital admission in such patient. And in a lot of patients, appendectomy was done for fearness that the patient has impending perforated acute appendicitis. As the name indicates that familial Mediterranean fever occur within families and is much more common in individual in Mediterranean descent than in person of any other ethnicity. Mutation in the Mediterranean fever gene appear to cause the disease in most cases. Mediterranean fever gene produces protein called pyrene. Uninhibited pyrene activity results in uncontrolled production of interleukin-1, leading to episodes of inflammation with accompanying fever in the peritoneum, pleura, and joint. Persistent subclinical inflammation is also common. These inflammatory episodes in persons with familial Mediterranean fever lead to excess production of amyloid A protein. This protein can be precipitated in the kidney in a long period, lead to chronic renal impairment, and this is one of the most common serious complication of familial Mediterranean fever. This is a picture for the most common feature of familial Mediterranean fever, polycerositis, abdominal peritonitis, chest pleurisy is the most common cause. Also, pericarditis can occur. Arthritis in large joint, muscle pain, tenderness, and swelling of the scrotum, and this is a recurrent disease, recurrent episode. Genetic testing is now available for familial Mediterranean fever, testing for a limited number of genes that may be appropriate in patients with non-ethnic background. 12 genes for familial Mediterranean fever is now available, and test for this genetic mutation is done in many laboratories. Colchicine is extremely effective in preventing the attack of familial Mediterranean fever and preventing the development of renal amyloidosis. But this colchicine is not effective when the episode occurs, so presence of pain must be managed by antibiotic. Also, recent biologic agent can be used as a second-line therapy, such as canakinumab. Management of PUO. PUO is not a disease. PUO is a manifestation of underlying disease. PUO is prolonged, the undiagnosed fever, and there is etiology for this disease. So management of PUO is management of the cause. When you manage the cause and you can treat it, PUO will disappear. But antibiotic is mandatory, especially in children, to avoid development of febrile convulsion. In adult, also, management of fever is mandatory in patients with bad general condition, and if there is associated cardiovascular or respiratory problem. Aspirin and NSAID, non-steroidal anti-inflammatory drug, or in some situations corticosteroids are option, but the most safe, the most commonly used is paracetamol. In patient with nosocomial PUO in patient with hospital-acquired infection, it has a special situation. It is polymicrobial, and usually it is drug-resistant bacteria or infection. So we must change an IV line or catheter. Empirical treatment with vancomycin for MRSA or broad-spectrum gram-negative coverage as piperacillin, tazobactam, ticarcillin, clavulanic acid, or Epidem group. It can be used before the appearance of culture sensitivity result, which may be delayed for 2 or 3 days. And finally, thank you. Thank you very much.